Uh, so today afternoon I am going to talk about the NMC curriculum, which is resistance in tuberculosis. So resistance is to the anti-tuberculosis agents. But before understanding the ATT mechanism of resistance, I will briefly discuss the basics of antimicrobial resistance. Antimicrobials include antibiotics, antivirals, and antifungals. So this is a very important topic, and I am going to give you a background of antibiotic resistance. What is resistance? Basically, it's a decreased ability or loss of ability of an antimicrobial agent, as I told you, which can be an antibiotic, antiviral, or antifungal. But the most important theme today would be antibiotic. So it has a diminished ability to kill the organism or to inhibit the growth of a microorganism. So like bacterial growth cannot be inhibited, so that is what is known as antimicrobial or antibiotic resistance. It is very important. Why? Because almost 1.2 million people have died annually of antimicrobial resistance, more than the number of people dying of malaria, AIDS, and breast cancer put together. So this is the highlight, that deaths combined together of malaria, AIDS, and breast cancer, and on the other hand deaths due to antimicrobial resistance. So this is how it is clinically significant. And what is a nosocomial infection? What do you understand by nosocomial infection? Black t-shirt. What is nosocomial infection? Yes, stand up. Both of you. Idhar aa jao. Come here. Yes, what is nosocomial infection? What is the full definition of? After how many days? 48 hours, and this is what is also known as HAI. No, healthcare associated infection. So why is it important? Because the rate in ICUs is more than 20%. So multi-drug resistant bacterial growth in ICUs is more than 20% as compared to non-ICU patients. And the problem here is that the nosocomial infections are due to resistant organism in 70% of these infections. Emerging new resistant and MDR pathogens is on the rise. So it is always prudent to acknowledge that over 3 million deaths in India are from preventable infections. So see the magnitude of infections and deaths due to multi-drug resistant pathogens. So this is a hot topic today, and the fortunate thing is that it is preventable. Now another important thing about antimicrobial resistance is that each individual institute has its own antibiogram and own resistance pattern. So pathogen here in Mahatma Gandhi hospital would be different from a pathogen or multi-drug resistant bacteria from SMS or from other medical colleges. Now, why this antimicrobial resistance has lagged behind? Because development of newer antibiotics or newer antimicrobial is sluggish. What are the disadvantages of antibiotic resistance? It leads to longer hospital stays, hence higher medical costs, and of course sometimes these bacterial infections can be fatal. So that's the importance of resistance. MDR pathogens were limited to hospital setting before 1990s. So that is an important statement, but then MDR pathogens were described to be affecting outpatients in healthcare settings. So inpatient before 1990, but then nowadays even outdoor patients are showing multi-drug resistance. And as I told you, it is preventable. So all means should be made to prevent antibiotic resistance or antimicrobial resistance. Now these are the statistics of prevalence of ICU infection. Overall rate of infection worldwide in ICUs is 14.7%, and you can see here the increase in resistance, the VRE, which is vancomycin resistant enterococci, increased from 24.7% to 33%. So these are the recent studies done in 2015 to 2019. MRSA from 53 to 56%, Pseudomonas from 16.4 to 25%, Acinetobacter from 11 to 30%. You can see the importance of Acinetobacter organisms, Bombini infection, which are causing drug resistant or antibiotic resistance. Klebsiella from 10.4% to 25%, E. coli from 3.9 to 9.0%. Now there was a study which was a cross-sectional one-day study across 35 ICUs in India, and the number of patients covered were 680 patients. So multicentric point prevalence cross-sectional observation study which showed that the multi-drug resistant organisms were to the tune of about 45% in various ICUs. So this is a very, very significant and a challenging figure. Now as I told you, there has been a lag in antibiotic development from 2010 onwards. So from 1928, which was the golden period, to 1952, lots of antibiotics were developed. So there were a plethora of hits, but from 1990s the development of antibiotics was very sluggish. This is what is known as discovery void. So you can see here the ascending, this is the ascending curve and this is the descending curve. So after that the antibiotic development was very sluggish. And how do they bring about the resistance? This is the bacterial cell wall, cell membrane, and this is the cytoplasm of the bacteria. Now the bacteria have become very smart and developed system to tackle the antibiotic in order to protect themselves. How do they do so? They induce mechanisms of entry to the entry of antibiotic to the cytoplasm or exit of the antibiotic from the cytoplasm. So the entry of antibiotic, like for example beta-lactam antibiotic, this is through porine chambers. So these are channels which are known as porins. So reduced number, differential expression of porins, or decreased influx. So this all leads to decrease in the antibiotic concentration within the cytoplasm of the bacteria. Another important mechanism is that these bacteria have developed efflux mechanisms in which they throw out the antibiotic out of their cell membrane. So increase in the number of efflux pumps they have been developed by. The examples here are macrolide like azithromycin or fluoroquinolones or tetracyclines. Whereas beta-lactam, these antibiotics have developed resistance because of the porine differentiation or entry channels of the bacteria. Now, there is another mechanism which is by production of certain enzymes. ESBL is the group of organisms in which is known as extended spectrum beta-lactamase antibiotics. So resistance to ESBL strains have also been shown, and this is because of development of certain enzymes like carbapenemase, NDM, New Delhi Metalloporphyrin 1 or MC. These are the various enzymes which can destroy the antibiotic. And of course, what is the meaning of PBP? Penicillin binding proteins. So these bacteria can also alter the target binding site like vancomycin or beta-lactam. So these bacteria can have more than one mechanism of resistance, leading to a pan resistance or multi-drug resistance. This is again the diagram showing the efflux and influx mechanism plus the enzyme production. So this is almost similar diagram, and you can see the antibiotics are effluxed fast or they are inhibited to enter the cytoplasm. What leads to emergence of antibiotic resistance? Overuse of antibiotic. So antibiotics should always be prescribed in a rational manner. Irrational use of antibiotic leads to resistance. Inappropriate prescription of an antibiotic is again important. Approximately 30% of the antibiotics are incorrectly prescribed. So you have to empirically decide, like in sore throat, if you give amikacin, that is an inappropriate choice. And sore throat mostly is due to viral infection, so don't use antibiotics in such cases. But if it's a bacterial origin infection, of course you can use macrolides. Extensive agricultural use of antibiotics in cattle. This is again an important, because these antibiotics would pass in the cattle milk and would induce resistance in the population consuming the milk, which has been infiltrated with these antibiotics. So overuse of antibiotics in the cattle, that is again very important. And of course then 2000 onward, there has been a lack of availability of newer antibiotics, and then regulatory barriers. We can see that in our country you can go to the counter and get azithromycin or clarithromycin or cephalosporins. So regulatory barriers of course are there. So antibiotics should always be sold on a prescription, but this is not being done. So that is the regulatory barrier. So how do we define multi-drug resistant organisms? They are resistant to multiple unrelated classes of antimicrobial and usually resistant to all but one or two commercially available antimicrobial agents. So what it induces? It induces 3 times higher mortality rate, 9 times higher rate of bacteremia and 2 times longer duration of hospital stay. Examples of multi-drug resistant strains are MRSA, VRE, gram-negative organism. Important ones are Pseudomonas, Acinetobacter, Klebsiella, Enterobacteriaceae, and NDAM1 Klebsiella pneumonia, which was detected in Delhi a few years back. Persons who have received antimicrobial therapy in preceding 90 days are prone to develop multi-drug resistance. Hospitalization for more than 5 days, high prevalence of resistance in the institutional variability. Patients who are on immunosuppressants like steroids or other chemotherapeutic agents used for cancer patients, frequent contact with healthcare personnel, concurrently caring for multiple patients at the same time. So this could lead to nosocomial resistant infection. And of course, COVID impact has also influenced the resistance pattern in the community. So, how do you prevent or delay antimicrobial resistance? Stewardship is the most important component. Right drug, right dose, right route. So, these are the important components of antibiotic stewardship. So, they should not be prescribed casually. Avoidance of antibiotic treatment for commonly acquired, mostly viral or upper respiratory tract infection. De-escalation of antibiotics is very important. Use of less broadly acting antimicrobial. So, you have to use targeted antibiotics for infection control. Narrow spectrum antibiotics should be used whenever possible. Antibiotics should be given for the shortest possible duration. There was a study between 7 days antibiotic use and 14 days antibiotic use. In a large meta-analysis, it was revealed that in UTI, bacteremia, if you give antibiotics for 7 days, it is as good as use of antibiotics for 14 days. So, shortest possible duration should be the timeline for antibiotic use. And of course, many of the antibiotics use can be handled just by hand hygiene, isolation practices, contact precaution, patient decontamination, device specific strategies. Now coming to anti-tuberculosis drugs resistance, as already been described in previous classes, it is one of the leading causes of morbidity and mortality worldwide. Resistance to commonly used ATT is increasing. It is estimated that 160,000 deaths from MDR-TB occurred in 2022. Global burden of MDR-TB is large, roughly 500,000 individuals, and is almost completely uncontrolled and is on the rise again. When was it recognized? So, drug resistant TB was recognized in 1940s, just after the discovery of streptomycin. Patients who received these drugs usually had marked and rapid clinical improvement within first 3 months of therapy, but treatment failures were also frequent after 3 months. So, that was the advantage of giving a single drug for a disease. So, later on this concept, like in antibiotic resistance, use of multiple drug therapies was initiated. Isolates of Mycobacterium tuberculosis obtained from patients with treatment failure were invariably streptomycin resistant. Rapid development of resistance to single agent led to the principle of multi-agent chemotherapy of TB that remains the cornerstone of treatment till today. So, single drug was not effective in tuberculosis, but this is not true for bacterial infections, because you can use single drug. There are specific indications of combination use of antibiotics. So how do we define drug-resistant TB? An isolate of Mycobacterium tuberculosis in the sputum or other with resistance to one or more anti-tuberculosis drugs. Primary drug resistance in a patient who has never received anti-tubercular therapy. Then acquired secondary drug resistance, development of resistance during or following anti-tuberculosis therapy in a patient who had previously had drug susceptible TB. So this is the primary resistance, healthy patient receiving anti-TB drugs and showing resistance. On the other hand, you have a TB patient who is MDR TB, has developed acquired resistance after use of anti-tuberculosis drugs. What is monoresistant TB? An isolate of Mycobacterium tuberculosis with resistance to a single anti-tuberculosis agent. Example is another rifampicin resistant TB, that is RRTB, an isolate of Mycobacterium tuberculosis with resistance to rifampicin. Multi-drug resistant TB, isolate from sputum or other specimens with resistance to at least isoniazid and rifampicin and possibly additional anti-tuberculosis agents. So multiple drugs are then resistant to treat the infection. Then there is another term which is known as XDR TB, extensively drug resistant TB, isolate of Mycobacterium tuberculosis with the resistance to isoniazid, rifampicin or a fluoroquinolone. These are the newer drugs which are secondary line therapy, and then of course there are second line therapy like linezolid and bedaquiline. These are the secondary line agent for tuberculosis. But then XDR is also becoming commoner these days, and then it leads to an increase in the mortality and difficult to treat infections. What is the geographical pattern? So you can see these areas. So these are areas with high prevalence of anti-tuberculosis drug resistance, includes China, India, Russia and the countries of the former Soviet Union. So Belarus, Ukraine, Kazakhstan, they have more than 20% of new cases which are rifampicin resistant or are showing multi-drug resistance. Another important fact is that these strains, they are difficult to treat, but they are not of virulent nature, or that they are not easily transmissible. The transmission pattern remains the same as of the Mycobacterium tuberculosis. So they are neither more virulent nor more transmissible than the initial agent. Now, risk factors for development of drug resistance in TB patients. The most important thing is that people do not complete a full course of TB treatment, inadequate or poorly administered treatment, HIV positive patient with active TB, or comes from an area of the world where drug resistant TB is common, as I have told you, Russia, China and India. History of close contact with drug resistant TB cases. So these are the factors, and the most important MDR TB factor is inadequate course of treatment. People do not complete the course as advised. So that's why this was replaced by directly observed therapy, DOT. 25% of the new TB cases in 1995 report demonstrated that there was an inappropriate use of anti-tuberculosis drugs. Compliance: patient do not take the drugs as advised. Patient characteristic, pharmacodynamics, etc., they are also important. So, individual differences in the pharmacokinetics include absorption, disposition and elimination of drug. This may lead to resistance to anti-tuberculosis drug, and it is true that a given dose does not lead to identical concentration time profiles in all patients. Concentration achieved by a particular dose is determined in part by patient physiology, gene alleles encoding enzymes involved in drug metabolism, dietary consideration, concomitant drug administration and other associated comorbidities like diabetes, silicosis, etc. Nosocomial transmission and HIV. Several nosocomial outbreaks of MDR TB have taken place in various hospitals or prisons, and this is much more common in patients who are suffering from HIV. Now, what is the basic of drug resistance as far as the molecular aspect is concerned? So, gene expert system for NAA testing for sputum for MTB, complex DNA and molecular detection of resistance to rifampicin has been approved. So, this has led to discovery of rifampicin resistance, isoniazid resistance. Burden of mycobacteria within a pulmonary cavity is estimated to between 10 to the power 7 to 10 to the power 9 colony forming units. So, this is the magnitude of infection in a cavity. Resistance to INH may be conferred by alteration in the CAT-G genes. As I have told you, there can be mechanisms of efflux, but this is not true here. It is the genetic alteration which leads to resistance in tuberculosis. So, this mutation accounts for about 85 to 90% of INH resistance. Again, rifampicin is a basic drug which is always to be used for initiation and maintenance phase, and this basic mechanism is by binding to RNA polymerase, resulting in interference with transcription and prolongation of RNA. Mutation in rifampicin polymerase gene leads to mycobacterial resistance. Then PZA resistance is due to any of the number of mutations in the gene PNCA. This can lead to pyrazinamide resistance. So, all four important drugs, they have the mechanism attributed to genetic changes. Ethambutol, again EMB gene is responsible for ethambutol resistance, and again streptomycin, though it is not a primary drug for use these days, and told you in 40s it was the first one to be used as a single agent and resistance was there. And of course, then secondary line drugs, they are also now showing resistance like ethanamide or quinolones. So, coming back to the summary of antimicrobial resistance. So, what do? To adjust or stop antibiotic therapy as early as possible to best target the pathogen and remove pressure for resistant development, which is known as de-escalation. From a higher generation antibiotic, go back to a lower generation antibiotic if required, and use it for the shortest possible time. Establish proper antimicrobial stewardship policies in the hospitals and monitor them periodically for adherence. Get effective antibiotic selection right first time. Base antimicrobial selection, both empirical and targeted, on knowledge of local susceptibility patterns. Use broad spectrum antibiotics early in severe sepsis. That is the golden hour. First 1 hour is crucial in severe sepsis. So, hit it early, hit it hard. So, appropriate use of antibiotics is very important. Optimize the antibiotic dose and route of administration. Administer antibiotic as infusion, as well as double the dose of antibiotics in severe sepsis in cases of multi-drug resistant organism infection. Administer antibiotic for the shortest possible duration to be effective. And now coming back to ATT resistance, drug resistant TB refers to resistance to isoniazid, rifampin, pyrazinamide, ethambutol or streptomycin. So, any of these primary drugs. MDR TB refers to an isolate of MTB that is resistant to at least isoniazid and rifampicin and possibly additional chemotherapeutic agent. Primary drug resistance said to occur in a patient who has never received anti-TB therapy, whereas secondary drug resistance refers to development of resistance during or following chemotherapy in patients who had previously had drug susceptible TB. So, I have already described the factors leading to resistance in these cases. Responding to drug resistant tuberculosis is possibly one of the most profound challenges facing global health. So, it is of very crucial importance to tackle the anti-TB resistance in order to eliminate TB by 2035, which was the WHO theme, as I already described you in the last. So, the WHO has estimated at least 400,000 cases of MDR TB which occur annually worldwide. China, India and Russia and the countries of the former Soviet Union are estimated to carry the highest number of MDR TB. Understanding the molecular basis of drug resistance in tuberculosis is gaining importance in rapid diagnostics testing, but fortunately we have these modern systems of gene expert and molecular determination of drug resistance, which hold promise for more rapid diagnosis and tailoring of drug therapy for the patients and contacts. So, this is all about antimicrobial resistance and resistance to anti-TB drugs.